Pleasure to be here, and it's a pleasure to have worked with Giselle all these years. Fortunately, she did not emulate the beard in terms of the type of doctor she wanted to be. Much of the preclinical data that I will present at the beginning of the talk is actually Giselle's work. So the data is hers, the mistakes are mine. I'll take credit for those. To give a little bit of background, Nifurtimox is a nitrofuran that is clinically used primarily for the treatment of a parasitic disease, Chagas disease, which is caused by a trypanosome. This is a disease that is endemic in Central and South America, affects about 10 million individuals, and it tends to become a chronic disease after the acute infection. People will have the parasite in their blood, sometimes for decades, and then a percentage of people will go on to develop heart failure. So it is a very common disease in South America where this drug is used therapeutically. And Nifurtimox works by creating free radicals that cause cell damage. Like many antiparasitic drugs, it actually has many more side effects than, say, antibiotics, because the parasites biochemically are very similar to humans, and the specific side effects of Nifurtimox are neurologic, and it turns out that in the presence of catecholamines, which are involved in the synthesis of neurotransmitters, you get more free radical formation. So this affects normal neuronal cells, but it also has the potential for affecting and increasing the free radical formation in neural-derived tumors, such as neuroblastoma. About 8 or 9 years ago, we had a young patient at Rhode Island Hospital with neuroblastoma, refractory neuroblastoma, and I actually got the call when she was admitted to the hospital with fever, and our pathologist said, "Bill, I want to talk to you about your patient with Chagas disease." And I'm at home furiously leafing through a textbook trying to figure out what Chagas disease was while carrying on what I hoped was a coherent conversation. And it turns out that this was came from a blood transfusion from an immigrant from South America who was completely asymptomatic, was doing their civic duty by donating blood, but was infected with Chagas disease. And so the little girl got Chagas disease, and we started her on Nifurtimox. And it became apparent over the next few months that the Nifurtimox seemed to be having an anti-tumor effect. So Giselle, with the prepared mind, took the drug to the lab and showed that indeed it causes cytotoxicity in neuroblastoma cell lines. So more Nifurtimox, increasing cell death, and that this was mediated by apoptosis or programmed cell death. So again, a tunnel assay, and in this assay, yellow equals apoptosis, and as you increase the amount of Nifurtimox, you get more apoptosis. You get increased expression of caspase-3, which is a mediator of apoptosis, and you can basically shut off the cytotoxicity by adding a compound that interferes with caspase-3. So a very nice story for drug-mediated cytotoxicity and apoptosis in neuroblastoma cells. And so, emboldened by the laboratory evidence that our clinical observation may actually have been true, we embarked on a phase 1 study. This was a couple years ago now. And of course, the primary objective was to determine what dose of Nifurtimox we could give safely to children with relapsed or refractory neuroblastoma, both alone and in combination with chemotherapy, because there was in vitro data to suggest that Nifurtimox acted synergistically with chemotherapy. The secondary objectives, of course, would be to look at the processing of Nifurtimox in children, because we didn't have a lot of pharmacokinetic data, and to see if there were any responses. So again, this is the schema for the protocol. Children, after their initial evaluation and determination of tumor status, would take Nifurtimox, which is an oral drug, daily for 3 weeks. They'd be reevaluated to see whether there was tumor progression or tumor response, and then continue on Nifurtimox with topotecan and cyclophosphamide added in fairly conventional doses. I mean, this is a combination that's been used in relapsed neuroblastoma for some years now, and then again continue to evaluate their tumor status and their toxicity. Again, some more details. Nifurtimox basically continuously throughout the course of the trial, with the chemotherapy coming in together with growth factor support, because this is a myelosuppressive combination. We started at the conventional treatment doses of Nifurtimox for the treatment of Chagas disease, and the plan was to enroll 3 patients per level until we saw a toxicity that would be considered unacceptable or dose-limiting, sort of stick at that level, and then work your way back to the maximally tolerated dose, and again to evaluate patients as you went along for tumor response. 14 patients were enrolled. These are the clinical characteristics, the most important of which I think is that the vast majority of patients had seen many, many chemotherapy trials before. So these were patients who had grown through or been resistant to many different drugs, and I believe all of them, or almost all of them, had seen the combination of topotecan and cyclophosphamide before. This is the toxicities that we saw, really very little at the conventional clinical dosing for Chagas disease. Some toxicity here, but sort of acceptable toxicities. When we got to 40 milligrams per kilo per day, we saw 2 dose-limiting toxicities. One neurologic, which again makes sense given the data in terms of increased free radical formation in neuronally derived cells, but one pulmonary hemorrhage that was actually probably related to necrosis of tumor, but still was a toxicity. Went back to 30 milligrams per kilo per day, which was determined to be our maximally tolerated dose. All 14 patients were evaluable for response to Nifurtimox by itself. And although we saw no radiographic responses in that group by the usual criteria, we did see 6 patients who had stable disease. And as we heard so eloquently early today, stable disease can really be quite important. 2 of those 6 did have responses that weren't radiographic responses, but that were encouraging, again, for drug activity. One child who cleared bone marrow disease, and one who had a significant reduction in secreted catecholamines. 10 of these 14 patients received at least 3 treatment cycles, and so could be evaluated for the response to combination therapy. And here we actually saw 3 partial responses. And again, this is a group that had seen the chemotherapy drugs, the conventional chemotherapy drugs before, 5 who had stable disease. So actually a pretty good response rate if you include stable disease, and a progression-free survival of 7 months, whether you had stable disease or partial response, again, in a group of patients who, most of whom had been relapsing pretty quickly. With this data, we then devised a phase 2 trial, which would be a more formal evaluation of how active Nifurtimox was by itself and in combination. And in this trial, we also included patients with relapsed medulloblastoma, again, based on laboratory evidence that medulloblastoma responded to this drug. And as outlined in an earlier talk, medulloblastoma, again, is a tumor that at relapse has no consistently effective treatment. We had secondary objectives to not only to look at scientific questions, but also quality of life and neurocognitive evaluation. Again, a drug that has neurologic consequences, neurologic side effects, we wanted to make sure that those weren't unacceptable. And the original design was to give an expanded upfront window of Nifurtimox alone, so 6 weeks of therapy with Nifurtimox, and then segueing into the combination therapy, much as we had done in the phase 1 study. And so evaluate response here, and to add in zoledronic acid, which is a bisphosphonate that has 2 potential benefits for patients with bone metastases. One is that it directly decreases pain associated with those metastases, which is a good thing, but also it has evidence for anti-tumor effect. And some patients indeed had a very nice response to Nifurtimox. You can see shrinkage of tumor here. You can see a pretty dramatic improvement in MIBG scanning. But as we looked at the patients, particularly the patients who were coming in with multiply relapsed disease, we became concerned that the 6-week window was really too long for the patients who weren't going to respond or who responded transiently. And because of that concern, we went back and redesigned the trial to really start with the combination therapy at the beginning. So Nifurtimox, topotecan, and cyclophosphamide from the start, because we no longer had the opportunity to look at single agent responses, we decided to use historical data for topotecan and cyclophosphamide as our basis of comparison. And to keep from confounding that response data, the zoledronic acid was dropped out. This is the statistical design, and there were three strata, or are three strata on the trial. The first is for neuroblastoma patients in first relapse, so those coming off from frontline therapy. The second for patients with multiply relapsed neuroblastoma, and then the third stratum for medulloblastoma. And the sample size and the responses were really taken, again, for historical data for the responses in that group. So in first relapse, where the response rate was felt to be about 30%, we felt a clinically significant response would be 50%, multiply relapsed patients less responsive, and the medulloblastoma even less responsive. To date, as of the data that I had, you can see 13 patients, one in the first strata, so first relapse, who actually experienced a complete response. This is a moving target. I'm sure there's more than 10 evaluable patients, and their analysis is still ongoing, so I didn't provide statistics for those. But we have had two patients in strata 3, both of whom had objective responses. As you can see here, tumor samples, I'm not sure it projects very well, but they're smaller. And again, tumor deposit that got smaller. So we're actually very hopeful that as this continues, that we'll continue to see responses and that this will provide us with a basis for going forward.